Hi, my name is Alvaro Alencar. I'm a member of the lymphoma program at University of Miami Sylvester Comprehensive Cancer Center. We're here at ASCO 2018, and I'm going to review the most important practice-changing abstracts in hematology malignancies. So we'll start with the myeloma session, and probably one of the most important abstracts was the presentation on the study ARO that evaluated two different schedules on the use of carfilzomib in combination with dexamethasone in treatment of relapsed refractory multiple myeloma. So in one arm, patients received the standard dose with twice-weekly dosing up to 27 milligrams per meter squared. In the other arm, patients received a once-weekly dosing up to 70 milligrams per meter squared. And interestingly, the once-weekly dosing was associated with improved responses, actually, from approximately 41 to 62% of response with the once-weekly dosing, and also improvement in progression-free survival from 7 to around 11 months. So very interesting, easier for patients with only once-weekly dosing. And actually, a poster demonstrated that combinations are acceptable with this schedule, so we should be looking forward to using this dose instead of twice-weekly dosing in myeloma. The other interesting abstract was the use of CAR-T in myeloma against BCMA in a group of approximately 43 patients with very refractory disease, approximately 7 to 8 median lines of previous lines of therapy. And on the study, what we see is very good tolerability, very little CRS, very few neurotoxicities, usually very well managed, with impressive results, approximately 80% very good PR or better, and around 95% response. So we're certainly going to see more of CAR-T in myeloma. A phase 3 trial is expected, so we're definitely going to see more of these therapy in myeloma as well. On the leukemia session, one important study was a study on ivosidenib. Ivosidenib is a sibling to anazidenib, which is the anti-IDH2 inhibitor that has already been approved for treatment of relapsed refractory AML with IDH2 mutation. So the IDH1 inhibitor, ivosidenib, presented very similar responses than what we and method of response as we see with anazidenib. Some differentiation, usually very well tolerated, fast responses, approximately 40% overall response rate, 33% complete responses. One interesting aspect is that patients that even didn't have response demonstrated improvement in transfusion dependence. So very interesting drug that most likely will be seeing shortly an approval for treatment of AML. Another study that was presented was the NSTOP, which is evaluation of interruption of treatment with nilotinib in patients with CML. The interesting part of the study is that these were patients that had already received a previous line of therapy with imatinib, so they had achieved at least, or should have achieved MR 4.5, so complete molecular remission at a 4.5 log, with at least 2 years of therapy with nilotinib. So these patients received an additional year of nilotinib and then had therapy interrupted if they maintained the complete molecular remission. And what we see is that around 55% of these patients maintained the response without therapy, and most patients, around 93% of them that required reintroduction of therapy, again responded. So more emphasis that interruption of therapy is feasible in CML. And on the lymphoma session that was presented yesterday, probably the most important abstract was the abstract from Relevance. Relevance was based on the very encouraging data, very appealing data with the use of R-squared, rituximab, and lenalidomide in the treatment of follicular lymphoma. So we have seen very good responses in first line, second line. So this study was a very audacious study trying to demonstrate superiority of R-squared compared to R-chemo. What we see is that the study did not meet the endpoint. R-squared was not superior to R-chemo, but in reality it was very similar, overlapping progression-free survival curves, overlapping response rates, and much less toxicity. So patients in R-chemo received 3 times more growth factors, had more infectious complications, even more infectious complications requiring hospitalization. So suggesting that while the study did not meet the endpoint, there was still a very good option for treatment in first line and follicular lymphoma. It's a chemo-free therapy, which is very, very appealing in some circumstances. And staying in this idea of chemo-free regimens, other important studies presented at that session were these studies in CLL. One of them was the study Captivate, which evaluated the combination of venetoclax and ibrutinib in first-line CLL. Every patient responded. The overall response rate was 100%, very fast MRD negative states, around Over 70% of the patients had already achieved MRD after 6 months of therapy, over 90% after 12 months of therapy. A little bit of worse toxicity with the combination, with more GI toxicity, more neutropenia, but still very tolerable. An excellent combination with the amazing responses. And we see follow-up data on the Murano study, which evaluated the combination of venetoclax and rituximab versus bendamustine rituximab in relapsed refractory CLL. In that study, we also see a very impressive MRD rate for patients treated with venetoclax rituximab. So again, chemo-free therapies with very impressive results and very good tolerability.